Hello, everybody. I'm Dr. Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation, otherwise known as Joey. We have tonight a fantastic article and a fantastic topic, and one that I feel is extremely timely. We are also pleased to have the authors of the article here with us tonight. I'm going to share the screen of the article itself. The effect of community type on access to orthopedic services for Medicaid insured patients. Just to give everyone a little perspective, 20% of the country has, 30% of the country has Medicaid, 10% are at least are uninsured. The rest are not living large. So this type of topic represents 40 to 50% of this entire nation. All right. Because people are in and out of Medicaid and Medicaid populations. What is really fascinating to me is that there is a constant discussion about Medicaid access for Medicaid patients for primary care, which I do think is important. But without specialty care, people are not getting fractures fixed. People are not having the opportunity to get their low back pain addressed. And there's a lot of issues related to specialty care. I'd like to introduce Vani Sabizin, who is I'll call you the senior author for a lot of fun on this. You just want to introduce yourself for a second, and then I'll introduce the rest of your team.
Yeah, so my name is Vani Sebastian. I am passionate like Ira about this topic. I think it's so important. Sometimes we look at so many of our surgical techniques and our innovations, but sometimes we don't understand and look at the access to care. So I personally am passionate, and I'm really proud of the group that helped write this article. Faye is on. I think Devin's on, and our team was really just thoughtful and trying to maybe publish something that might be controversial. And thankfully, Joey really helped support this in this conversation tonight. So thank you. Thanks, Ira. As always, I really love Joey for the fact that it really sort of is innovative and thoughtful and provoking.
Thank you so much. I also like to introduce Howard Routman, who is a bit of an expert on this topic. Howard, you want to say a couple words or not?
Greetings from Florida, and we look forward to talking about the challenges that we have in our state with this problem. And congratulations to Vani and the team for putting together something that's really thought-provoking. Thanks for having me.
Oh, it's great having you. So, Faye, you were the lead author. Give us a little bit of the origins about why this group wanted to study this issue.
All right, so we really wanted to look into how insurance impacts access to care in different, not necessarily different regions, but I guess like how different insurance types can impact access to care. So with this particular project, we initially were looking into how Medicaid insured patients might have decreased access to care, but we saw that there are already many studies regarding that. So I thought of the idea to come up with community types. I come from an immigrant family where access to even care such as primary care is limited, and it's usually in families who are in rural areas from where I'm from. So I figured, why not look into our home, which is South Florida, and see if we would see similar trends regarding the use of Medicaid. Sorry, I'm so nervous. So
Don't worry about it. You're among friends.
But
or as we like to say in New York, we know where you live. Don't worry about it.
Okay. Well,
you're doing great, and the article was wonderful, and this is very interesting. So educate us.
Okay. Yeah. So I kind of just thought about how community type affects access to care. I'm at the Charles U. Smith College of Medicine at Florida Atlantic University, which is in Boca Raton. And coming from like North Florida, when you think of Boca, you think of like people living large, they have a lot of money. But when I came down here, I didn't realize that there was such a disparity in terms of like the wealth gap. So I thought it would be interesting to look into areas that you would typically think of being wealthier, which were like the 3 urban counties that we looked at, to compare it with areas that are more rural. And so that's kind of where this all came from.
Excellent, excellent. Devin, you're on? I think I saw.
Yes, sir.
Yeah, so what did you guys find?
So actually it's pretty interesting. So our paper kind of had a lot of findings since we were kind of comparing insurances and geographic locations. And we broke up the data into many different formats within those variables. Basically, the main difference is between the insurance types, Medicaid versus private, which is pretty well known. But interestingly, rural, like whether they had, like for example, Medicaid patients, whether rural or urban, there was a 10% rate of them having access to orthopedic care. So their geographic location didn't affect their access in that way. However, there was an increased wait time in rural communities, regardless of, or actually, there was a decreased wait time, but an increased travel time in rural communities, which is kind of interesting that there was a decreased wait time, given that, you know, one of the sources we cite in the paper said that there was 30% of rural hospitals have full-time orthopedic surgeons. So given such a small number, we would have expected there to be an increased wait time in rural communities when actually we didn't. That's not what we found. So pretty interesting in that way.
Interesting. If anyone has any comments, they could also put them into the chat if they have questions, or they could just blurt them out. Every once in a while, I'll switch to see if anyone decides to raise their hands. I'll also start with another question. Why do you guys think? You said there's 10% of the people had access to specialty care. Is that right? Is that what you said? One out of 10 people.
I'm sorry.
1 out of 10
I think it's more. Yeah, I was gonna say more. 10% of the clinics really took those patients and accepted them.
That's what I meant to say.
In the way that we measured it, it was a 10% access.
So what do you think are, let's go right into solutions a little bit. Why do you think that's so, especially in the urban community, in urban centers?
I mean, I think there's a lot of reasons. I mean, I think part of it is reimbursement rates. Medicaid notoriously has lower reimbursement rates, and the cost of healthcare in general, the cost of everything is increasing. The cost of an education is increasing, but reimbursements for Medicaid is decreasing. So it creates a challenge and a disincentive to see these patients. Additionally, I think there's stigma that along with it. I think everyone, when we talk about Medicaid patients, everyone has an image in their head. And when you think of private insurance, you have a different image in your head, I think. And I think that honestly kind of plays into it as well.
Right. Anyone have any comments on that, on the idea of the reimbursement before we talk about it?
Well, I can't believe they're decreasing. And when I first started, I think I got $8 to reduce a Colles fracture in the emergency room for Medicaid in New York. So I can't believe it's even less than that. Maybe what you can buy is less than that.
Well, I don't know what the 8 states that were studied in the Gwynn article that was cited, but Florida was at the lowest of all 8 states in terms of the reimbursement for Medicaid payment. So Florida has a bigger challenge because our Medicaid rolls swelled during COVID from 3.5 million to over 5 million people in the state on Medicaid. And during that window of time, the folks that were on Medicaid were protected because of the pandemic legislation that made it prohibited people from being disenrolled. And now that that's passed, there have been 1 million people disenrolled from Medicare in the country, and Florida is #1. We've disenrolled 300,000 people from Medicaid, many of which are actually people that qualify for Medicaid. But because of the way that they notified folks about the disenrollment, they didn't know they were going to be disenrolled. So people now have to go back and re-enroll in order to be able to get care.
Wow. Charles, do you have a comment, or you didn't raise your hand?
Ira, I think that we looked at our own hospital. You know, we're inner city level 1 trauma, and we looked at our own hospital numbers. just a while back because we had a diversity, equity, inclusion dinner. And when we looked at that, it's fantastic for a residency program to look at this diversity of population of people with insurance and those with the differentiation of, is this private pay or is it Medicaid like we're talking about? And that's an eye opener, but it also lets people experience the difference potential in care that they can have and what we can provide as trainers. And so as trainers, we're going to treat everybody the same, right? So that's the beauty of it, no matter what that is. And it's good for at least training programs to get that experience to all the people that we have the benefit of teaching.
Any other comments on this? All right, I want to bring something up. I work in a hospital that is a private, not-for-profit safety net hospital. 85% of our patients are below the poverty line. And we have 85 to 90% Medicaid or Medicaid HMOs. Okay, that is the payer mix. The thing we talk about in the South Bronx, nobody comes into the South Bronx for their care, and no one leaves the South Bronx for their care. So it's a closed urban population. So one of the ways that we address this is hats off to our CEO who recruited me out of private practice. And we started off with 3,500 clinic visits and 200 operations when I got there. And now we are 50,000 clinic visits and about 2,600 major operations. And orthopedics is a huge revenue generator for the department. And so why would a physician work there for $8 a Colles fracture? And the reason is because the hospital on the Part A actually collects quite well in Medicaid. And if the hospital invests in better salaries for physicians and better leadership, you actually have a chance to deliver care. That's my thesis on that. Any thoughts on that idea? Because I think we're very aggressive at hiring talent at a higher starting salary than most places, and the hospital pays it for the fact that they used to do no joint replacements. Now we do 600 a year, and 600 at about $24,000. This is actual numbers. We average $24,000 a joint replacement due to the comorbidities primarily, and that adds up to being able to pay for some of the services that don't work out. Any
But
more?
Ira, don't you think that's the solution that needs to be reproduced all around the country? I mean, that's the problem. We don't have these models.
Well,
Not everywhere. Ira,
Yeah.
kudos to you for driving the program. You've done tremendous work since you've taken over there, and it's really grown. So kudos to you. Now that I'm part of NYU Langone, Long Island, I'm part of 18 faculty, and we cover from Queens to Montauk, and all comers, and we control all the trauma. So we take care of it as a group, and we share, and there's a productivity model. But I don't know what everybody makes, and I don't care what everybody makes. We just want to do the best care possible. And we're ranked number 4 in the country. And we're ranked number 4 in the country, whether it's for a Medicaid patient or private pay. Everybody's treated the same. Y cuando puedo hablar español con mis pacientes, hablo español con mis pacientes. In New York, I grew up bilingual. We've taken care of so many different people. It's a pleasure to take care of all different races. You have to be very respectful to so many different ethnicities that we have here in New York. It can be hard with languages sometimes.
So, yeah, Howard, were you going to say something?
Yeah, so I wanted to ask you a question about how you guys manage some stuff, because one of the things that we struggle with is, well, obviously within our practice, we take care of patients on our Medicaid, and we take care of the problems that they have. But some of the challenges that we run into is in the postoperative care and the required postoperative treatment, and so much of the outcomes for the work that we do can be tied to postoperative access to therapy and being able to do a good job in that point. You can do a wonderful job doing your joint replacement, but if they don't get access to therapy afterwards, and their outcome ends up being jeopardized. How do you manage that within your system? Because it's a big challenge for us.
It's a great question, and I think it's the number one problem that we started looking at around. I've been there 15 years. So about 12 years ago, we started aggressively looking at outcomes, especially related to hand surgery and shoulder surgery, because the knees and the hips. If you ask Chit Ranawat, he'll tell you, you don't even need that much therapy for that. If you ask Andy Wickline, you can not get away, you can educate patients very aggressively on post-op exercises. But in hand and shoulder, very important to aggressively have physical therapy. So first of all, we're a little bit of an urban Kaiser Permanente. We have a huge physical therapy department in the hospital and a number of outposts in the South Bronx that we support ourselves. So our solution was hospital-based. And then we also found a number of certified hand therapists that we have contracts with that they could be part of our system and take care of the patients. Remember, we're Medicaid HMO, so we negotiate with the Medicaid HMO. But most importantly, it was our own internal solution. I think we see close to 38,000 or 45,000 PT visits a year. And so we aggressively invested in our own PT because we were seeing disasters. I mean, our manipulation under anesthesia rate, Howard, was huge, was absolutely huge. I don't know if I told you it was like 12%, it was I would probably be low. So we really aggressively started investing in some pre-op episodic care management programs. We started with one. Now we're in a different one that does some virtual physical therapy. We're aggressively doing that. But we look at ourselves as a urban Kaiser, that we have to take care of the whole episode of care. One of the advantages, which is maybe not as the same in Florida, one of the advantages we have is that physically, the South Bronx, from a geographic point of view, does not have a lot of travel problems. You can get anywhere by subway, by car, Access-a-Ride, which is a Medicaid-based access. So we really, in fact, my first job was 5 years at Kaiser Permanente, and I kind of stole a little bit of their model to do and the fact that we're private, not for profit, means we're not answering to the city of New York. So the CEO can decide, we can have a discussion between the CEO and I about how we're going to take care of these hand patients, how we're going to take care of these shoulder patients. So I think an integrated delivery system may be the model for at least urban centers, because it doesn't make sense in a $24,000 hip replacement. Why should Dr. Koenig make $130 or $250 for Medicaid and the hospital's making $24,000? Well, since we share an employer ID with the hospital, we can split a little bit of that $24,000. But in private practice, there needs to be other solutions. Yeah. Any comments on this?
Well said, Ira. The one thing that I think has driven this is the electronic health record. Even though we've all cursed it out at times, it's made that office without walls possible. So we can cover for multiple locations, have access on my iPad, my phone, to everything. It wasn't like that 40 years ago. So
Right.
It makes these solutions more possible. What are they doing in Florida different? Because we do the same pre-op education. We educate our therapists. We also educate our home care, and we used to run our own home care program too, because that's important. Have your eyes out there and your nurses sniffing anything ahead of time. I think more in the future we'll go to remote patient monitoring. I think those apps are going to get stronger as well, and that'll help at least orthopedic surgeons monitor their patients. But how are they managing in Florida now?
In a nutshell, pretty poorly, I think would be the answer. I think that Yeah, when you look at nationwide in terms of the tightness of restrictions for access to even getting on Medicaid, and then being able to access care within Medicaid, Florida has one of the most restrictive set of rules to be able to qualify for Medicaid. So if you're a single parent, if you are a single adult without children, regardless of your income level, you are not qualifying for Medicaid no matter what. In the state of Florida, actually there is a exemption from that individual being able to get on Medicaid. Now, if you are a parent of a child, you're able to have if you're 35% above the poverty line, then you can qualify as a parent. As a child, you can qualify if your household has, I think it's like 250% above the poverty line. So in all the states in the country, Florida is one of the most restrictive, and right now is in the process of disenrolling a whole bunch of folks. And the people that they're disenrolling are sick children and people with disabilities that now have to go back through the whole process of requalifying for it. And the Department of Children and Family Services, which is responsible for determining eligibility, they were not built and staffed to manage this size of a problem with the disenrollment that's happening after COVID. So now they have a huge lift ahead of them to try to find it, and they're genuinely trying to help, but they're not prepared for it. They don't have the ability to manage it. For us, when we're dealing with patients in the clinic that we've operated on, we go out of our way to try to give them a home exercise program so that they know what they're supposed to do, and we can try to educate them as best we can. We have a therapy center in our clinic that takes care of patients of ours, but the therapy center doesn't take Medicaid, but we'll grab our therapists and pull them into the room and say, show this patient how to do the right exercises so they can do it on their own. And then they'll go to the place where they can get therapy and try to follow the instructions we give them.
But I mean, the only thing I would say is expansion nationwide still is increasing. So there's a lot of Obamacare alternatives to Medicaid that have really grown in exponentially. I mean, Ira, one thing I think is just provocative, and I might throw out there sort of just in terms of solutions other than a contained health system. I mean, how do we teach our trainees how to take care of these patients and make sense of it, right? How do we address the health disparities, the access, and tell our young trainees that this is an important part of our problem solving that we need to do and address? I might put it out there for our young guys, sort of, because, 10%, 90% of clinics were not taking it. I mean, that is a huge exponential, selection bias here. And other than your type of system where we really turned the economics around, I don't see how there's an incentive for these people and young people to take care of these patients.
I mean, if anyone wants to chip in, fine. The question I have always is, if Medicaid paid the same as Medicare, would more people in private practice or in a group practice or a large group practice or a hospital practice that has contracts, would they decide to take CMS plans if there was just one CMS?
In the state of Florida, the answer would be yes, I think. Because the cost of doing business continues to rise and reimbursements continue to decrease. In the state of Florida, as opposed to other states, Medicare is one of the better payers.
Right. Interesting. I'm gonna put a couple people on the spot. I'm gonna ask Jeff, because you're at Princeton Orthopedics, which is, in my opinion, one of the premier practices in the Northeast, and I sincerely mean that. If Medicaid paid Medicare rates, or even 5% above Medicare rates, what do you think would happen in significant groups like yours?
Yeah, no question. The in my practice and my hospital is Penn Med, Princeton Medical Center, after they purchased the hospital. There's a beautiful clinic there, and we all put in our time, but it is spread out amongst enough people that no one feels that they're there that often. It tends to be the rotation is comfortable. We don't even submit bills when we see Medicaid patients in the emergency room. So it's a hospital rule that if you're on staff, you cover the emergency room and you cover the clinic. And so we don't even submit for reimbursement. Now, that's not the hospital. I'm sure the hospital, as you said, Ira, is doing quite well by all of those things.
Yeah.
But it's a personal pride that you're taking care of your community.
Yeah.
Now, if you actually say, as a businessman, I'm the business manager for Princeton Orthopedics, then you'd say, if you went above Medicare by 5%, you'd probably be going above some of the private insuring payers. I'll bring up one just small feature, and I don't want to distract from the momentum of the evening, because it's really been a great education for me. I had to review an article, and I think it included Florida, New York, and maybe a few other states, about access to care, Medicaid, in students, meaning student athletes. And it was remarkable how well student athletes were being managed in terms of the percentage. And again, it had to do with whether or not they initially were in an emergency room, or whether they went to the school physician or the trainers, and how they got the introduction to it. But it would be much better than what we're reporting tonight in terms of these student athletes getting access to care. Was primarily for ACL injuries. And so it just, there are certain carve outs to this conversation, but I think there has to be more than just a doctor responsibility. If you're going to take, university hospitals utilize all kinds of areas, the VA system, for instance, for educational purposes. But private practice is really probably the biggest chunk of orthopedists in this country. And you need to have them engaged in this system somehow. And so some of the suggestions made tonight, maybe the government taking on a different role in terms of how it deals with hospitals and private doctors. You can't pay someone $8 to get up in the middle of the night and go to an emergency room and push on a fracture. It's just not right. There is a way of doing it, and it is expensive, or more expensive than what they're currently doing. But I think that legislatures will have to get together and create an environment, as this is becoming a pandemic of its own. And you need to be able to treat your citizens, and everyone should be able to go to a physician or an emergency room and get proper care, as opposed to being excluded. So that's how I feel. We do fairly well. I think we could do better, but I think we do fairly well because of the hospital building a wonderful clinic and staffing it. So I think the part of it is you don't feel like it's a major sacrifice because you're doing something like this. You feel good about the service you're providing.
It's a great points, really was. Any comments on that?
Yeah, along those lines, I think that, particularly in Florida and other places, one of the biggest areas where Medicaid is managed incredibly well is in the pediatric population. And I think that if you're looking at high school students that have ACL injuries, I think that pediatric orthopedic surgeons and pediatricians, at least in our state, they have a very high percentage of Medicaid patients that they treat. And once your practice becomes like a pediatric practice, I don't think would survive down here if it did not accept Medicaid.
Up in New York here, orthopedics has really invaded all the schools through sports. So our sports docs are there, our athletic trainers, and we're oftentimes some of the first touches for the hospital. And once you get the moms on board, then you get everything else, the OBGYN, all the other subspecialties are involved as well. So what the former doctor said was very, very true. By controlling the athletes, or at least reaching out to them, sometimes that's the first touch to the families of the underprivileged. One other point I wanted to bring up, and I love the discussion tonight, but we haven't spoken about the undocumented. So you put this population on top and the undocumented, and they're both hitting the same clinics oftentimes and the same systems. It's really a burden to the system, and there needs to be a little bit more investment from the government, just based on numbers, and to be able to support more nurses and more CSTs, more operating rooms. I mean, we can go on and on and on.
It's really fascinating. We were at I'm taking a surgical leadership year program at Harvard Medical School, and the first slide they show is Don Berwick's, who used to be the head of CMS. As quality goes up, costs go down. But the scam of that slide, because Berwick was head of CMS, and I know he's a famous guy and probably much smarter than the entire AAOS in their minds. But the reality is that if you don't have access to patients, the quality is going to go down. If patients don't have access to orthopedic surgeons, then they're coming late for treatment. Instead of seeing a fresh Colles fracture, you're seeing a Colles fracture 6 weeks later. Instead of seeing a bimalleolar fracture fresh, you're seeing it 4 or 5 weeks later. You have to, recrack the fibula, move over the syndesmosis. I mean, there are a lot of issues. And I think that I think it's irresponsible of the government and of some hospitals to put rules in place that the private doctors have to do things to get privileges, but they're not paying them. And I'm just bringing that up. It's not my situation. My situation, we are an integrated practice model that has been working extraordinarily well. But I'm going to push on the other side and say there's no reason why a hospital that is probably making for that Colles fracture the solid facility fee of $600-800 is not, sharing that. And everyone depends on the goodwill of the doctors. But as someone brought up earlier, all the costs are going up for all the doctors where we are. The cost of training residents, training people going up. The cost of medical school. I mean, Stanford Medical School probably costs $300,000 a year now. Not a year, over 4 years. Although Stanford has probably a $30 billion endowment. I'm trying to understand this disparity in the shift of money, how the physicians are getting burdened by the financial burden when there is money out there. It's just being shifted elsewhere. Some thoughts about that.
Yeah, to Dr. Koenig's point, I think that with regards to the undocumented patients have even a harder road to hoe right now, particularly in our state. On July 1st, a new law comes into effect that requires hospitals and emergency rooms to actually just required to ask their status when they come into the emergency room. This is a part of a larger crackdown from the current administration of state. There are a lot of folks that are really scared right now in the state of Florida because they already have limited access, right? And now it's becoming even more limited. And I think that in the end, just like you're saying, if the injuries are going to happen, and we're duty bound to take care of these folks, regardless of their insurance status, regardless of documentation, by not gaining access, it just makes their care more challenging, and the results not as good.
Ira, quick question or a quick statement, just to piggyback on what was said. The same way there are doctors who feel like in order for them to maintain privileges at a hospital, they have to provide certain activities to either the emergency room, clinics, and other things. Well, I'm not sure why the government, who's giving the hospital its privileges and credentials and its licensing, maybe not the correct word, but its ability to serve as a hospital, maybe they need to have those similar requirements to be leveraged on them. That part of hospitals work with budgets, and their budgets tend to get blurred when it goes over and covers the areas that they're not doing so well and areas where they are doing so well. And we hear, that a physical therapy department in the hospital is $600K in the red. That's impossible. I mean, it's a captured audience. So we know that that budget is being blurred with other budgets, and that's how they come up with that justification. Well, if the government can bring out the fact that there is this need for hospitals to provide their covering physicians, and sometimes you have hospital employees that are involved, but there's also the private sector that covers the hospital.
Yep.
I think there is a way that the government could step in and put some pressure on the hospitals.
I think so. And, I think it's, redistribution of wealth. Ira, specifically, your system has done that, right? The hospital profits and then shares that with the physicians. And if there's a shared collaborative sort of incentive, I think that it's a win-win for everybody. And I think that that's a big problem is the hospital lobbies, the lobbyists are really strong, and that really has driven funding, resources, and those type of things.
All of our passengers.
That's a great point. I'm gonna for a moment I'm gonna introduce I think she's still on. No, my hand surgeon in the hospital, Sepida Vaghi, and there she is. Sepida, in my opinion, one of the premier hand surgeons in New York, which makes her one of the premier hand surgeons in New York. And she's been with the department for 15 years. So she has been taking pus out of people in the Bronx for 15 years, fixing hand fractures. Sepida, you want to unmute, maybe tell a little bit of your own opinion about this? And we have a strong department seeing a lot of patients. You know what it was like when day one, when no one had access, but some of the challenges you see and maybe some opinions from your point of view.
Yeah, I have plenty to say about that. I guess what triggered me was what someone mentioned about what was going on in Florida and how physicians are going to be mandated to ask people or patients rather if they're undocumented or documented. I think that's insane, and I think that goes against everything that this country stands for. That's not our job. Our job is to treat people, and that's what we've been doing here in the South Bronx. We've been treating undocumented people, patients without papers, patients with no insurance, patients with no social security number. But that doesn't get in the way of whatever treatment that they need. So I just find it really mind-boggling and unethical, actually, if that becomes part of something that a physician has to do. Like, we're not ICE. We're here to treat people. It doesn't matter, whether they're documented or undocumented, but we're just here to treat patients. And that's we took an oath on that. And so it's been challenging here in the Bronx, but I would hate to see that having to inquire patients about whether or not they're documented or if they have papers becomes the norm. I think that's really bad optics and unethical.
Oh, I couldn't agree with you more. The current leadership in the state is using it under the guise of trying to prevent human trafficking. That's their reason that they're saying they're doing it, but it's a very thinly veiled excuse.
You can still report child abuse and human trafficking without asking questions about documentation.
I think I agree with that. I definitely agree with that.
Sepida,
there are patients who come in and they're afraid to even seek care because they think that they're going to be reported to immigration services. And so, what I do, instead of asking them if they have papers or not, I just ask, listen, you don't have to worry. We're not interested in that. That's not, we're not going to report you to anybody. We're just here to treat the issue or the problem that you have, and that's it.
What are the biggest problems, access-wise, that you find post-operatively? I'm going to back up to something we talked about earlier. Now that you're on, Sepida. I brought up the idea that I felt that we have a lot of challenges. We solved a number of things, but some of the big challenges are in shoulder and hand, upper extremity, PT, OT. Are you finding decreased, less than optimal outcomes because of some downstream inadequacies of availability?
Yeah, I think that the success of my specialty is mostly on it's very heavily dependent on therapy after treatment, whether it's surgical or non-surgical. It is, I would say, at least 70% based on the quality of therapy that the patient is getting, the timeliness and the quality. And you know, when I first started practice, you know, for a long time, I was kind of beating myself up because my patients really weren't doing well. And then I realized they weren't getting therapy in a timely fashion post-operatively. You know, I recommend therapy for 6 weeks and the patient would be back in 6 weeks and they still hadn't had any therapy. So that's my specialty, definitely is heavily reliant on therapy for successful outcome. And I think that's really important. It's an important resource to have available.
Yeah. Any other comments on that?
I'd
Hey,
like to throw one
Dr.
more
K.
thing out. Go ahead, please.
Okay, hey, Aaron Wilcoxon here. I suppose, first of all, hats off to the authors on a great paper.
Yeah.
And thanks to Ira and Joey for this forum. From somebody from industry, it's awesome to listen into your dialogue and read the paper. On the topic of outcomes, I actually had 2 questions if we have time for it. So the first one, and I suppose it's for the authors probably, although anybody, please feel free to chime in. At the company I work for, we talk a lot about dissatisfaction, specifically after knee replacement, whatever that number is, 20%, 10%, something. It strikes me that the socio-demographic factors that may be indicative of dissatisfaction after knee replacement also are present in the Medicaid population specifically. So, for instance, lower income, non-white, seem to be some similarities. So I suppose my question is, are the authors aware, did you guys look at any sort of correlation between the two? So drawing a line connecting access to care with specifically satisfaction, or if not, are you aware of anybody who's asking those questions and looking at that specific for, I guess in this case, lower extremity joint replacement?
Devin or Faye, you want to try that?
We didn't look into any correlations between satisfaction and like Medicaid insured patients. I honestly haven't like seen much about dissatisfaction in regards to like recent literature. I'm not sure if Devin has seen anything like that.
I also am not aware of satisfaction in relation to insurance.
I'll tell you specifically what I was referring to, and I'm sure a lot of the people on the call will have seen this too. But actually, a crew in New York, I think, recently published back in October, at least, a systematic review looking at, how many total knee patients really are dissatisfied. They found that the number was about 10%, and when you subtract out complications, that number fell to like 7%. Of which the majority could be predicted based on, again, those kind of socio-demographic factors. So to me, anyway, I thought, well, maybe there's something here in terms of access to care, and then also, satisfaction specifically.
It's very interesting that Vin Dasa, who's one of the deputy editors of Joey, and people know Vinod Dasa pretty well. He actually did a study showing that it's a study about studies. He showed that nearly almost no joint replacement articles covered outcomes related to social determinants of health or race. That's one of the articles that he published in Joey, and he published a bigger series in Journal of Arthroplasty. I would like to say the first article came in Joey, and JOA was an afterthought, but that's a separate issue. It's not being studied. One of the reasons why I think Devin and Faye said they're not aware of it, because it's not being done. One of the things we do every year, we have a group of summer fellows. One of them's on here, Millie. I see her there. Hi, Millie. We try to reproduce studies that have been done elsewhere at, let's say, special surgery or Mayo Clinic, because we have a different population. And so when we say, what are the results of a medial pivot knee and kinematic alignment, someone like Millie or Ben, who've been our fellows before, will do that study in our environment. And we'll talk about race, income, and other things. And we've gotten a few of these published, but you're right. It's not a big literature out there. It's not a big literature out there. What are some of the future studies you guys are thinking of doing? Devin, Faye, Vonnie, what studies do other people think need to be done right now?
I was going to throw out that somebody should be looking at artificial intelligence and solutions for the situation.
Good point. And Robert, you were going to say something?
Yeah, Cleveland Clinic just did a study where they looked at socioeconomic differences and outcome. And they found that they had to define what they mean by socioeconomic outcome. So they did a grading scale. They called it the Area Deprivation Index. And they took the area that they were studying around east side of Cleveland and the treatment area, and graded the patients on multiple factors to give you a different range of instead of saying you're just a Medicare patient and that's it. And they found that there's a great scale. And I think you were just, the undocumented are a great example of they don't fit the standard Medicare patient and so on. There's different levels of Medicare and found that, one thing I want to go back against Aaron on is race, because what they found out in this study was it didn't matter if you were black or white. If your socioeconomic level was at 90 to 100, which is the worst, or 60 to 70, race didn't matter. You still had basically the same relative outcome because of the factors that all play into your daily existence, your ADL. So maybe more work in those areas, looking at the, where in that scale is the worst, and maybe addressing, maybe the way you address it is differently across the scale of ADI.
I've seen data like that, and also medical literacy runs into the same thing.
Mhm.
Poor outcomes with poor medical literacy. So educating the patient and the families reaching out.
Mhm.
It depends on your location. It's so multifactorial. New York is such a broad area, so many different immigrants and so many different cultures. But what you were saying about socioeconomic class, I completely agree with. It's not black, white, yellow. It's if you're very poor and don't have access and education, you're not getting the best. You don't understand what you're getting. You don't even know what you need.
Exactly. You're not aware of, this is what I need to go see. I need to go see a specialist. I need to go see this person because I have this issue going on. And that gets put off because I got to go to work. I got to do whatever I've got to do for the household. So it's so crazy multifactorial, but I think it's a need within the study realms of understanding our populations and being able to treat those populations.
It's a great point. I just want to point out, interesting. We did an abstract that was accepted at ISTA last year on health literacy in Spanish-speaking populations versus non-Spanish-speaking populations with the same economic status. We actually found lower health literacy in the pure Spanish-speaking population, and that was just a pilot study. We're expanding it on a larger study, and we don't know why yet. They may be newer immigrants to the United States. We're not sure. We have to subdivide the data a little bit more. But it was interesting beginning to begin to parse out that kind of data. We're towards the end a little bit. This has been went quite quickly. I want to thank everyone who spoke. In here are potentially a number of solutions. I will put Faye and Devin on notice that we expect to see more research from you guys. You did a phenomenal job on this article. We were very pleased to get it. It got nearly 400 views. And to give you an idea, the average journal article in most academic journals gets between 35 and 67 views. So this article got 388 views and quite a number of downloads. So it got you guys should be very proud of the work you did as young researchers. And we here at Joey, we're a young journal. We've been in business for 3.5 years, and we want to thank you for choosing us for your good hard work. Does anyone else like to make some final comments, Howard or someone, to bring us home?
Sure. I just want to congratulate Faye and the team for putting this together. Faye, I tell you, although you say you're nervous when you were speaking, you did a great job. You represented us very well. And I think that you telling your story as to why this was personally important to you, that is one of the things that makes for a good researcher, finding something that really gets into your head and chasing it. So congratulations, good job. And now you're the lead author on a paper that's had over 400 people really demonstrate interest in the field where it's usually a lot smaller. So well done, Shay and the rest of the team. It's good to see you, Garrett. Nice tie. And other than that, the whole Atlantis and Sebastian crew, nice showing tonight, guys. You did a great job. And Ira, thank you for giving our research team the opportunity to present its data.
Oh, it's my pleasure. My pleasure. So I want to thank everyone who spoke tonight, and this will be posted within a week on the Joey site, so people could look at it, show it to their trainees, show it to their colleagues, show it to their congressmen, councilmen, state senators, show it to the governor of Florida if he's listening. And with that, I'll say good night to everybody.